Good evening, everyone. Welcome to the first ever virtual Palm Beach International Equestrian Center educational series presented by Adequan here at the Winter Equestrian Festival. My name is Miranda Tiona, and I am happy to return for the 2021 season as the educational series coordinator here at the Winter Equestrian Festival. I am delighted to virtually spend 12 weeks with you every Thursday at 6 p.m. Eastern Standard Time to learn. This past year has been very challenging, to say the least, and after careful consideration, we did decide to go virtual this year given the COVID-19 pandemic, but we are very thankful to be here with you, and we do recognize that this is a great luxury to be together virtually. As this season is virtual and new for all of us, please bear with the speakers, the sponsors, and myself. We are all learning and trying to navigate this new virtual experience. And in order to help you all navigate as participants, I'm going to quickly go through some of the functionality for you so you know how to engage directly with us. So if for whatever reason you need to reach out to me and only me, no one else will see it, you can utilize the chat function that is at the bottom of your screen. It's a little icon that says chat. That is to me and me only. If throughout the session you have any questions for our wonderful speaker today, I know she will love it. Feel free to utilize the Q&A icon at the bottom of your screen. The Q&A will be only seen by myself and the speaker, and she will do her absolute very best to answer your questions. If for whatever reason we are inundated with questions and we don't have enough time, feel free to send me an email and I'll be happy to get that question answered for you directly. All right, to view the recording of this session, which we are actively recording live, please visit the PBIEC website and click on the Educational Series tab. There you will find a video archive, and you'll also find the registration page to be able to register for all of the wonderful sessions to come. Please also keep in mind that it may take a few days for the recording to be uploaded to the website. Lastly, I would like to say a huge thank you to Karina Brez Jewelry for providing a luxury item, which I have learned what that item is, and it is very exciting. It is a limited edition light pink diamond 18 karat rose gold horseshoe necklace valued at $3,000 for the grand prize giveaway. So how it works. For every session that you attend, which we can see if you attended, we have all the stats to do that, you get one entry. And you do get one entry. So essentially that means that there is an opportunity for 12 entries if you attend all of the sessions. And the winner will be announced April 1st. You don't have to be present for the April 1st. And if you can't make it, that's okay. We will then be sending through email for you to claim your prize. So make sure that you check the email that you registered with. Now, with all of that said, let's begin. I am delighted to introduce today's topic and speaker. Today's educational series session is sponsored by the Wellington Regional Medical Center, and the topic is Ouch, My Aching Feet with podiatrist Dr. Elizabeth Davis. Dr. Elizabeth Davis is a native of Steubenville, Ohio. She's a graduate of Bethany College in West Virginia and the Ohio College of Podiatric Medicine. Having completed a 3-year foot and ankle surgical residency at Memorial Healthcare System in Hollywood, Florida, Dr. Davis prides herself in providing her patients with state-of-the-art foot and ankle care. She is board certified by the American Board of Foot and Ankle Surgery and has a special interest in wound care, limb salvage, and elective podiatric surgery. Her practice, LA Podiatry, has 2 convenient locations, one in Wellington and one in West Palm Beach. And Dr. Davis is on staff at both the Wellington Regional Medical Center as well as the Center for Wound Care and Hyperbaric Medicine. In an effort to give back to the community, Dr. Davis volunteers with the Special Olympics and serves as a trained clinical director for their Fit Feet program. In her free time, she enjoys being active outside, spending time with her German Shepherds, traveling, and doing creative projects. Her compassionate and bubbly personality allows her to foster genuine physician-patient relationships and provide quality care for all of your lower extremity needs. Now, without further ado, I would like to welcome our guest speaker, Dr. Elizabeth Davis, to begin and take it away from here. We're very, very excited to have you. So thank you again so much. And I will let her run the show, and don't forget to unmute.
So as Miranda said, I'm Elizabeth Davis. Obviously for podiatry, our practice and our scope of practice, depending if you travel from other states or areas, can vary state to state. In Florida, we pretty much treat anything orthopedic from the knee down, as well as soft tissue from the hip down. So I'm just going to talk today about some common things, pretty much the most common things we see in everyday clinic. And then I tried to add some equine specific injuries or things that may be more a little bit pertinent to you. If at any point, I'm like more of an interactive kind of girl. So if you guys have questions about something during it, I'll try, and I'm also Zoom handicapped. So if I can answer the question while I'm going, I will. If not, we'll get to them at the end. But I do love input and feedback. So one of the big things people come into that I see frequently is just basic issues of why is this happening? You know, everyone has different foot structures, and which usually leads to different compensations, different deformities, and why what may be great shoe for me may not be a great shoe for you. So the three most common foot structures we see are neutral arches, which would be what you see on the left, as well as in the middle, you see what a plantar pressure would be on someone who has a flat foot. And then on the far right, you can see someone who has a high arch. So someone who has a high arch has less surface area to put pressure and would tend to put more weight on the outside versus someone who has a flat foot that puts weight on the inside. So these different abnormalities, if we go through what life, which most people do, picking beautiful shoes and maybe not practical shoes or shoes that may not be supportive, our body and our biomechanics has different ways to compensate for that. And then that's where usually most of the foot issues come from. So this is just another depiction of that. So bunions is textbook probably the most common thing you think of with your feet and podiatry. Also the most common thing, everyone thinks they have bunions and they're pointing to all different parts of their feet, and it's usually not a bunion. So a bunion is a deformity we see. It's usually behind the big toe joint. Usually a prominence develops on the outside of your foot, usually causing irritation or pain. Sometimes we see the large toe drifting towards the smaller toes, and sometimes can even go under or over the adjacent toes. Bunions aren't always painful, but they can become painful with time. If you develop a similar prominence on the outside of your foot, that's called a Tailor's bunion or a bunionette. They are significantly more common in women, as well as people over the age of 60. And if you get them when you're young, they're typically related to genetics. When you get them a little older, more likely it's related to your shoe choices throughout life or lack of support or motion. So conservatively with bunions, we always start with things like padding or shoe changes. The problem with most people with padding is you have a larger bump, so you're adding padding to it, to an already narrow shoe. So usually a soft toe box or a wide width shoe is a great place to start. If pain gets a little bit more severe, topical or injectable steroids or anti-inflammatories or even oral medications work great too. And then eventually when that stuff doesn't work, sadly, it's a surgical fix, which every time I've ever taken care of an equine rider, no one has time for that. So similar to a bunion, and often commonly confused with bunions, is something called Hallux Limitus, which is actually arthritis in your big toe joint. So I call people this the bunion on the top. Your big toe doesn't move up and down as much because the bump gets in the way and just because of general narrowing of the joint. And eventually it progresses to something called hallux rigidus when it no longer moves anymore. And we see this specific deformity in people who tend to have high arches, which have a lot of pressure and motion there. Also, people who do jobs or activities that require a lot of squatting and bending. So, and then this will kind of sound redundant, but a lot of our conservative care in podiatry is managed very similarly. So both with bunions, Taylor's bunions, and big toe joint arthritis, using something like orthotics control that abnormal motion and foot structure we talked about. So they slow the progression from these deformities from getting worse, but they also take away that motion that may be aggravating it. So sometimes just shoe changes or adding an insole and then treating the inflammation or symptoms with the same oral or topical medications and injectable steroids. So I won't keep harping on the treatment, but again, we always try the easy stuff first. And then when that doesn't work based on the severity of the joint, there are various surgical options. Probably the second most common thing I see would be hammer toes. Commonly confused, everyone thinks the little lumps on their toes are corns. While hammer toes can cause corns, a hammer toe is essentially a bending of the toes. Depending on what joint they occur, they get different names, but it causes contractures at various levels. When you get them earlier when you're younger, they're typically reducible, which means when you press on the top or your shoe presses on the top, they straighten out and tend to be less symptomatic. But as we get older, they tend to move less. So people develop either blistering or thickening of skin on the top of the toes or even on the tips of the toes. They can even develop hard or soft calluses on the top or in between. So there's various types of padding that can help alleviate pressure or symptoms. A common thing I see a lot, people love to use like medicated topicals to treat corns in between toes, which usually sometimes does more harm because that skin is so thin and sensitive. So I always recommend seeing a professional. I'm sure everyone here, if you take care of a horse, you're competent in gently shaving down calluses, but actually removing the callus usually alleviates the symptoms, but a nice trained professional can do that for you. And it really alleviates complications of the deformity as well as makes you feel a lot better. And then padding. And again, when all of those easy things don't work, then you can have, surgical intervention to fix that. So metatarsalgia is kind of a generic word podiatrists use that describes pain in the ball of your foot. For me, this is probably a really big equine issue related, which I'll talk to you a little bit more about, an area that may hit home for you guys symptom-wise. So what jumped out to me when I was preparing this is, whether, doesn't matter what style of riding you do, but when you have your foot in a stirrup, you guys know more than I do about the balancing, the positioning, but the correct saddle or the stirrup placement is right in the ball of your foot, which happens to be a really complex structure. As we get older, we get natural fat pad atrophy, which you lose the padding in your foot, which makes some of these anatomic structures more vulnerable. So you already have an added weight and pressure on the ball of your foot. So the question is what structures are you irritating? A common thing we see is capsulitis or bursitis. So capsulitis is inflammation of the soft tissue structures around the joint. So in your foot, that's typically right behind your toes where they bend and go up and down. You can get bursitis in the ball of your foot or in general in a couple other spots if you look in the picture. A bursa is something that naturally occurs in areas of pressure and near joints in our body. I tell people to think of them like laundry detergent pods. They're little capsular jelly-filled sacs, and they're like little airbags or bumpers that protect important areas of pressure. Those can also become inflamed with repetitive trauma or irritation, whether from pressure from a stirrup or if your boot is rubbing you or even repetitively bumping maybe into the side of the horse. So again, these things are treated the same way. We want to control that abnormal motion, treat the inflammation, And then again, you can have injections. Sometimes as these progress down the road, then you have to have, again, more aggressive management. So neuromas, everyone comes in with something, they're stepping on a rock or a marble, or their socks bunched up, even if they don't have socks on, but they get an abnormal sensation in the ball of their foot. Another common symptom people use to describe neuromas is you can get numbness or tingling into your toes. Typically two. What a neuroma is actually inflammation. Some people call it a little tumor, or it's almost like a little nodule of the nerve, where a little ball forms where the nerve tissue becomes swollen from the irritation of the bones. And it's a plantar nerve, and it's actually the nerve that splits and goes to your toe. So depending on which nerve is irritated, the respective toes then have symptoms. And again, this is treated with various types of injections, offloading padding or insoles. This is, for me, especially with the style the equestrians wear with the narrow boots. You know, one of the treatments is trying to use something, again, more wide or soft at the toe box. And again, trying to alleviate the pressure, which is completely not practical for anyone who rides a horse. But another really common thing we see is ganglions. So ganglions are the most common benign soft tissue mass in the foot and ankle. They're really common at tendons and joints because they're made of, again, like the laundry detergent pods, similar fluid that you have in your joint or in the tendon sheets, which is this tissue around a tendon. These are kind of like funny little lumps that kind of stay in one spot but move around a little bit. They can change size at their convenience. They only hurt if they're pressing on something important, if they're in an area that the shoe may rub. But typically we only drain them if they're symptomatic. They're a pain in the butt because they love to come back. And typically to get rid of them long term, we do have to cut them out. And even sometimes they like to come back after that too. But again, really, really common. The old-fashioned way to treat them, if you want a nice home remedy, is to smash it with a big, thick book like a dictionary or a Bible. But I do not recommend that at home. So this is probably, again, in the top 3 most common things I see is heel pain. Everyone knows Google and Wikipedia and what plantar fasciitis is. They just don't know how to say it or spell it. So plantar fasciitis is pain that most people get on the bottom of their foot. It's typically associated with having a really high arch or a low arch. For some reason, everyone, it can be related to being overweight, but I see it all the time, no matter the activity level, the size of the patient. I 100% see it in people who spend a lot of time barefoot or using flip-flops or very flexible shoe gear. But the hallmark of plantar fasciitis is pain after rest. So if you wake up in the morning and you get out of bed, most people have to tiptoe to the bathroom. If they've been in a car ride for a long time and get out from driving, or sitting at a desk. And then once you get moving, it typically goes away. And if you ignore it long enough, it's going to hurt all the time. It's usually brought on by tight soft tissue that's on the bottom of your foot. It attaches to your heel bone and kind of fans out and helps support your arch. So what happens is when you're sleeping in your comfortable position, it becomes tight, and then you step down with your body weight, and it causes stretching and micro tearing and inflammation. So one of the easiest things you can do at home if you're having heel pain is to just kind of focus on stretching your arch and even your Achilles tendon. We treat it with ice, in some situations, injectable steroid. Again, always orthotics and various shoe changes, but most importantly, not walking barefoot at home. And contrary to popular belief, walking in socks at home still is barefoot. There is no support in your socks. Plantar fibromas, which can sometimes be confused with plantar fasciitis, if you look in the bottom left. So again, another type of benign soft tissue mass we see in the foot. These are more firm. Again, they can vacillate in size. They can get it, I've seen them as big as a golf ball. Again, only symptomatic if they're pressing on something like a nerve or a structure, depending on how close to the weight-bearing surface it is. Again, very high recurrence rate, even with conservative care. So again, treated with stretching, orthotics, and you can try injections of steroid. to decrease the size, but it's definitely one of the most frustrating things as a healthcare provider to treat. Thank God, you know, don't see them as frequently as we see other issues. Some other reasons we have heel. So this for me is the back of the heel. What we just talked about is mostly bottom of the heel. So a lot of people, your Achilles tendon is where your calf muscles and the back of your leg come together and they form a band of soft tissue that attaches to your heel. So their job is to move your foot up and down. For me, like just in preparing for this, like in looking at the positioning of riding, there's a lot of stress on your Achilles. You know, you're putting a lot of weight, bracing, impact, and stabilizing. So I imagine this is something that riders are also very prone to, but in general, people who like to walk, athletes, even people who work on their feet, very basic treatment is, again, stretching and good, firm, supportive shoes. Tendonitis hurts after rest also because it tends to be tight and needs to be warmed up, but it can hurt with physical activity also. So with tendonitis, you can also have what's called a Haglund's deformity or insertional Achilles spurring. So it's essentially a heel spur on the back and the top of your heel. And that's just kind of where your body responds to that tendon pulling for so long. A Haglund's deformity, if you look in that bottom left picture, is actually a bump. We see that more in women. It's called a pump bump. But it's from years of wearing high heels or heels with or shoes with a lift in the back. And it's actually just a more prominent bone on the outside. It's typically a surgical fix only because back of your shoe will always rub it, and there's nothing conservatively we can do to take away the deformity. Again, some anti-inflammatories will buy you time if it's not severe, but again, that's technically a surgical fix. And then Achilles tendon tearing and rupture can happen at any point. You know, a lot of these down the road in this presentation, I'm going to talk about some equine trauma. And I'm sure you're all familiar with being thrown from horses or, you know, getting crushed by horses or falling with your foot stuck in stirrups. Those are not an uncommon mechanism of injury for an Achilles tendon tear. In my personal practice, we see them a lot in what we call weekend warriors, people who aren't active and then they think they can go out and play a sport or lift something heavy or do an activity that they maybe just a little too strenuous for their age or physical stature. It's usually the men in their 40s and 50s. But again, can happen with usually a lifting or an explosive movement and typically with the ankle in a fixed flexed position. Again, depending on the severity, it ranges from immobilization, if partial tearing, to surgical fixing if you have a complete rupture. So this was something I specifically wanted to talk about because, you know, given your position in the stirrup, you have a lot of anterior ankle pressure. So an anterior ankle impingement is when you get pain in the front of your ankle. So it can be related to the bones butting up against each other, or even irritation and impingement of the soft tissue. There's a complex structure of arteries, nerves, and tendons that run on the front of your ankle. So that fixed motion, any of those structures can get irritated. So it can cause inflammation of the tendon, tingling or burning or irritation along the nerve. And then you can have that bone-on-bone pain, or essentially it's similar to arthritic pain from that long-term fixed position. You can also see it after recurrent ankle sprains, again, treated with various types of anti-inflammatories, ceasing the activity that causes it, rest and immobilization. So tendonitis and tendinopathy. Itis is your inflammation and opathy is your thickening with time or degenerative changes. So tendons are essentially the portion of your soft tissue where your muscle attaches to bone. So they're essentially, if you can see in the picture, all around your foot and ankle. Riders, very common to perineal, which is on the outside of your ankle, which is the outside of your calf, and also posterior tibial, which is actually in your arch, as well as on the front of the ankle, which we just talked about. You can aggravate or exacerbate your symptoms or recreate them by turning your foot in and out or up and down. You can have sensations of instability or weakening, and then you have more pain when you're actually participating in activity. Again, same type of treatments, rest, immobilization, and various anti-inflammatories. And we always want to, especially in like elite athletes or people who are really active, I actually treat these pretty aggressive, because what happens if you continue to ignore something like tendinopathy, it thickens and thickens, and eventually the tendons can give out, and then you get tearing or rupturing, which usually down the road causes a larger issue. So this little section is more about some common nerve issues we see. I get a lot of people who come in with tingling or numbness or burning in their feet. At the bottom, you can see, so peripheral neuropathy is one of the most common things. Again, Google tells people they have. But peripheral neuropathy is actually kind of a generic diagnosis for numbness, tingling, or what we call paresthesia, which is just funny feeling in your feet or toes. It's typically worse at night. It's most commonly associated with diabetes, but you can have it with certain chemotherapeutic medications, thyroid disease, nutritional abnormalities, alcohol abuse. There's idiopathic, which means we have no idea why you got it, but there's also various issues. So neuropathy, there's actually no cure for peripheral neuropathy. And in some situations, it can be progressive, meaning it gets worse with time. There are medications to manage the symptoms. Usually my role in peripheral neuropathy is to minimize the complications and risk in those patients. So examining them in people who, if it progresses to the point where they have absolutely no feeling, I do just simple maintenance, like in diabetics, cutting their toenails and shaving those calluses we talked about to prevent ulceration or skin breakdown. And also, it's not uncommon for people who can't feel, if they have a hard time seeing, to cut their nails and maybe cut off the tip of their toe or cut themselves. Something else which you guys may be prone to, which with repetitive falls or horse injuries, I'm sure some of you have back pain. Lumbar sacral spine, which is your lower back, all of the nerves that come out of there actually go down your legs and innervate your feet. So it's not uncommon that if you have a back injury in that area, that you can actually have numbness, tingling, or burning down your leg or just in your feet. So that's called radiculopathy. And in situations like that, similar treatments to peripheral neuropathy, but we typically work with either an orthopedic surgeon or a neurosurgeon or neurology team, or even pain management or anesthesia to manage the symptoms and hopefully fix the issue. An actual nerve impingement in the foot is something called Tarsal Tunnel, which I'm sure people are familiar with carpal tunnel. So it's pretty much the exact same thing in the foot. People present with numbness, tingling, or burning on the bottom of their foot. It's typically with activity. So I see it a lot in runners. They get going and it usually starts so far into the run and it usually stops with time after the exercise. It's the ligament on the inside of your ankle and where the calf muscles from the back of your leg kind of swoop in to go to the bottom of your foot. There's a soft tissue structure that commonly can pinch the nerve, which causes the burning and numbness and tingling on the bottom of your foot. So again, similar treatments. We treat the symptoms by injecting the nerve with steroid to calm down the inflammation, but then we fix that pathologic motion that's causing the pressure on the nerve. So hopefully it stops happening, which is usually corrected with orthotics. And we see this a lot in people with flat feet, because if you remember from the first slide, they tend to load more into the arch. So arthritis, I'm sure everyone here has some form of arthritis. In general, arthritis is breakdown of joints. They tend to dry up, they narrow, they get irregular rubbing. You can grow bone around the joint. Your soft tissue structures that support the joint can become thickened, but in general, it causes pain, and usually pain after you've been not using them for a while, and you have to take a little time to get going. And then sometimes just with activity and progression of it, you lose your range of motion, and some activity can, even simple like walking, can be painful. So osteoarthritis is your typical wear and tear that most people experience as we get older. There's various types of autoimmune, which I just named a few here: psoriatic arthritis, rheumatoid arthritis, that have very specific joints they affect in the foot, but can be very limiting and debilitating. For you guys, post-traumatic arthritis, any type of trauma can damage the joint down the road. Gout is something we see a lot. It's our rich man's disease if you love red meat, shellfish, wine, whiskey, all the good things, that can actually cause a flare of pain and arthritis in your joints, most commonly your big toe, your ankle, or your midfoot, that we can medically manage or even help you get more immediate symptom relief with injections of steroid also. Again, another thing which I added because we got an email when we were talking about this lecture, someone asked about clubfoot. I personally don't treat clubfoot, but I get a lot of like the deformities down the road. So whether people had a hip replacement and their limbs are uneven, or they had clubfoot or polio, you know, I get the residual deformity and I help with bracing, heel lifts to even up them to have a normal gait. But sometimes people need surgical intervention to correct any residual misalignment, or even if people have arthritis. The goal is to treat again with conservative care, like we talked about, injectable steroids, topical steroids, various oral medications. And when that stops working or bracing and rest doesn't help, then a lot of the times we can do either joint replacements or fusions of joints, which depending on what joint it is and the severity. And a fusion is just when we take that painful joint and make it one so it doesn't move anymore, but usually the pain goes away. So it's just a little picture to kind of show the different areas that people commonly get the different, most common types of arthritis. So this is another one. No one wants to show everyone their yucky toes, but I see them all day long, and you wouldn't be very surprised at how many people have toenail fungus or athlete's foot and don't want to talk about it. I have good news and bad news. Toenail fungus is one of the most frustrating things to treat. Nothing is 100%, no matter what TV tells you. But there are some more effective treatments. There's laser therapy, oral medications, and various topicals if you want to be cheap. I've had patients who Vicks Vapor Rub and vinegar soaks works just fine. But fungus loves dark, warm, moist environments, and Florida and closed-toe shoes make you far more prone, especially if you're out working in the, in the pasture or in the barn. It's prime real estate for fungus to spread. Athlete's foot, you can have redness and peeling, and some people they get blistering. You can just have peeling that maybe you think you're putting lots of lotion on your feet and it's not getting better. It could be athlete's foot, but it can itch and burn. It doesn't always. Ingrown toenails, again, it's usually pain in the corner of your nail. You can get redness or swelling or even infections from it. There's procedures we do in the office that can alleviate your symptoms, both temporary and long-term. We're always checking for skin cancers, however, very rare in the feet. We do see them, especially on the legs. Different various rashes related to eczema, psoriasis, allergic reactions to various like shoe material, or even if you're exposed to something. If you're wearing narrow boots, you can get dark coloring under your nail, which could be blood, which you see in that far right picture. Blistering. So I'll talk a little bit more about some specific blisters that more equestrians are more prone to, but blister management. And then most importantly, which is my 100% of my equestrian experiences in the last few months, are related to toe or nail trauma, because for some reason, everyone loves to wear flip-flops in the barn. So I'm here to tell you, put on your shoes, because it never ends well. Sometimes even when you have shoes on, it's not going to end well, because when you have a horse step on your toe, it just mathematically, it doesn't even out. So I've had open fractures, nails falling off, and various different lacerations. I've sadly had people lose their toes from horses stepping on it. So make sure you're wearing a nice, closed, safe shoe. So specific to blisters, I have read a whole exhilarating article on breaking in new riding blisters, and I was shocked to see how common it is that people were asking about different solutions. So I found a company that sells heel sleeves and also a posterior knee sleeve that protect the outside of your ankles and the back of your knee when you're breaking in your boots. But apparently it's not uncommon to have blister formation while breaking in your new riding boots. So just basic blister care, if they're clear, an easy way is to clean them with alcohol and use a little needle or a little sterile scissor, and you just make a little hole and drain it. But you want to leave that top on there because it helps prevent infection, and it actually helps with the pain too, because it makes like a natural protective barrier. And then usually when it dries up, the skin flakes off. If you have blood in your blister, we typically open that completely and then just use some topical antibiotic ointment. So this whole next section is more focused on more like the orthopedic trauma and the more high energy injuries you may see, especially common with equestrians. So high and low ankle sprains, obviously, depending on the barn, there are, various different surfaces and uneven terrain. So I'm sure everyone's familiar with rolling your ankle, whether it be in or out. What people don't realize is there's a difference between what's called a high and a low ankle sprain. So a high ankle sprain is where your tibia and your fibula, which are your ankle bones, come together, and the ligament that connects them and offers stability to the joint gets sprained. Typically, pain is increased with outward rotation, and it really limits when you go up on your toes or go all the way up with your toes towards your ankle. Those motions aggravate it. A low ankle sprain is our standard roll your ankle in or out. You can even actually tear off little pieces of your bone, which is called an avulsion fracture, depending on the severity. But the way I explain a sprain to people is a ligament is a piece of soft tissue that helps support two bones. It offers stability. So when you have a sprain, it's almost like stretching it like a piece of taffy. You want to rest and let it scar down. But if you keep having an injury, they keep stretching and stretching, and it makes you more prone to it. And can ultimately tear, and then it becomes like a cyclic issue. So this is probably, when you think, like in my training, when you say horseback rider, Lisfranc injury is the most common thing associated with equestrian trauma. And that mechanism of injury of being thrown from the horse with your foot in a stirrup is why that happens, because your foot is stuck, and then the force of your body rotating around the midfoot is usually what causes a fracture. So we can see these injuries both with breaking of bone or even just the soft tissue, but they're all equally severe and almost always surgically managed if you want to prevent complications down the road. These symptoms typically, the hallmark is aggressive bruising in the arch, swelling in the midfoot, but essentially just pain right through the center of the foot. In most people, it's very, very difficult to walk on it. And then obviously ankle fractures and what we call pylon fractures, which is a fracture of the larger bone of the ankle at the joint level. Again, similar injuries, these can happen being crushed, thrown from the horse with a severe sprain type motion where you roll your ankle. But essentially the bones that make up your ankle are broken depending on the size, how unstable it is, and the location of the fractures determines if you need surgery or if you are amenable to conservative care like a walking boot or even a cast. Sadly, most of the time, if it's involving the joint, it ends up being a surgical fix and a 2 to 3 month recovery of not walking. Another thing that we see, because the equine injuries tend to be a little bit more high energy, they can be an open injury. So an open injury means you may be called a compound fracture, but essentially when you have a wound associated with your fracture and the bone's exposed, and given the environment that most horses or equine events are in, they tend to easily become contaminated or dirty, so a higher risk of infection, but that's also something we manage. We see a lot of just in general lacerations, which require irrigation and repair. You may see hematomas if your horse, if you ever got kicked by your horse or landed on by the horse, which is essentially a large bruise under the skin that can become firm. Great if you put the heating pad. It takes a lot of time though for your body to resorb that. A rare complication we see is something called compartment syndrome. So the various structures in your foot and leg, you're made up of some firm materials, whether it's fascia or bone, and they don't expand. And you have various muscles and neurovascular structures that do swell with injury. And if they swell to the point that they can cut off your circulation essentially or damage the tendons and nerves because they have nowhere to go, it becomes essentially a medical emergency that needs to be surgically managed. And then every now and then we sadly see trauma that causes an amputation or just a severe injury, whether it's from crush or the complications of these that require amputation. So these are just some of the common ones I had. Sorry for being graphic. So that bruising on the left is just someone who's horse stepped on their foot. The one in the middle is what happens when your horse steps on your toe with your sandal. And then that's the thigh is someone who got kicked by their horse. So I'm ready for some questions if you guys have them. Let's see, we got a couple. Okay, first one, if you have an ingrown toenail, do you recommend having it surgically fixed or just leave it alone? So usually for ingrown toenails, I'm kind of old school and I don't like to touch people or do anything to someone unless it hurts. So if you're having repetitive symptoms or if you have any type of infection, then absolutely. Or if it becomes a recurrent issue, in situations if people are like diabetic or have comorbidities that make them more prone to infection, yes, sometimes we do them to prevent complication. But in general, when treating them, one, if you have infection over, we do want to treat them before they become infected. But in general, my rule of thumb is it has to be hurting in sneakers, or at least be symptomatic to justify taking it out. And it does require injecting numbing medicine and a little downtime after, but definitely a great long-term solution. So next one, can riding horses agitate or irritate neuroma? 100%. Yeah, so neuromas, the most common things that aggravate neuromas is that side-to-side compression of the forefoot. So in general, a riding boot, the style of it in general is going to irritate it. Most of them are made of a leather, so it has a little bit less give than a mesh or an open shoe. So stretching a boot may help, but the generalized pressure while riding in a stirrup can aggravate it. And then just speaking from someone who's like assesses shoes, I don't know anything about the stability of an actual like equine riding boot, but when you wear a shoe that's flexible, it allows the metatarsals, which are those long bones, to wiggle up and down, and that tends to irritate the nerves. So if you're wearing a boot that lets your foot have motion, that can aggravate your neuroma. So if you have blood under your nail, what is the best way, if any way, to address it? Do you have to drain it or let it grow out? So this is, I'm disappointed in myself for not talking about this. So the rule of 25% is how it goes. Well, in general, if it's more than 25% of your nail plate, your nail's probably going to fall off. So depending on if it's loose or painful, some people can just trim it back themselves. Some people have to come in and have us numb it up to take it off. If you just have a small area and your nail is well attached and you don't see any signs and symptoms of infection, you can definitely drain it at home. Most people heat up like a needle. I've seen people do it with a little cautery, but you just make a small hole in your nail and the blood usually comes out and typically alleviates any pain or throbbing you have. Whenever you have blood under the nail, it can happen from like running or shoe pressure, but we do see it a lot with trauma. So we always get nervous that maybe under your nail you have a laceration or a cut or even a broken toe underneath. So we do get concerned for infection and things like that. So sometimes it does require coming in to have an x-ray or a little second opinion to look at it. And another thing just to keep of note, if you're getting repetitive trauma or you have a horse step on your nail, your nail can fall off as it grows out and then even fall off a second time. And it can actually even cause permanent nail changes. When you get that trauma to your nail bed, it can make your nail thick and lifted and discolored, which looks a lot like fungus and is commonly confused with fungus, but sadly you can have permanent nail changes from that kind of trauma. So what is the best way to prevent or treat recurring toenail fungus every summer? Boots and humidity. So obviously drying your feet well and trying to obviously you have to be in a boot, but when you're not in the barn or in the field, trying to wear open shoes. Powder is great for prevention. It doesn't have to be an antifungal, but if you have a recurrent infection, an antifungal is definitely the way to go, especially in between your toes. If you're having symptoms, antifungal creams are great for the skin in the areas that are not in between your toes. Powders do well in between your toes because it tends to be a tight space and traps moisture. And then in general, if you're trying to treat your nails, if you're looking for something over the counter, anything that's like a lacquer or fluid based tends to absorb better. But in general, drying well. I've actually even had patients use various like foam spacers, or even have to use like something called, it's very old, but like lamb's wool, which you can buy at CVS. It adds a little space in between your toes and lets it breathe. And there's even another old school product called Gentian Violet that's obnoxiously blue and purple. You can even put in between your toes once or twice a week. That really helps dry it up too. Okay, next one. Someone asked me about foot complications in horses and ponies, and I have no idea about anything in horses and ponies, but I know I asked for one my entire childhood and never got one. Sorry. So I missed your earlier discussion on numbness. All of my toes will go numb and tingling while riding when my feet are in the stirrup or irons. It goes away after dropping my foot out of the stirrup. I have a longer stirrup length as I'm a dressage rider. Issues on and off for years. Any tips? So that to me, the neuromas are typically very localized, ball of the foot or toes. So something that causes diffuse numbness with activity to me sounds like something more like tarsal tunnel. And so there's functional and anatomic tarsal tunnel, which yours sounds more functional. If it's occurring when you're riding and improve when you come out, it's likely related to the position of your foot in the stirrup where you're stressing that inside of your ankle. And again, I don't know what the flexibility of a riding boot is or how much space is in a boot, but if they would accommodate an orthotic, which the nice thing is if you make a custom orthotic, we can make them very low profile and graphite, maybe more amenable to having that extra support to take the pressure off the nerve, or maybe try a different style, or I get they're mostly leather, but maybe a more firm style riding boot. But ultimately you have to take the pressure off the nerve. There are some people who get tarsal tunnel with any type of activity, but it could be from whether they have like a soft tissue mass or even a larger vein in the area, and it can just be anatomic related. So that's something when we're treating it, if they're not responding to normal care, that sometimes those people require actually releasing the nerve in the soft tissue structures. But I think maybe adding an insole if it's feasible in a boot, or trying a different style and more firm. And then also maybe paying attention to your riding form. I read a lot about the balance and the positioning in the stirrup, trying to stay centered. So someone who would tend to load on the inside would be more likely to have tarsal tunnel, which it sounds like that's what that is. So I did that one. Is it okay to have your ingrown nail removed at the pedicure salon? So I'm not gonna lie, I'm a very vain woman. I get a pedicure every 2 weeks, but I think it's all about going to clean places. I don't let people use dirty, unopened instruments on me. At the same time, I've bared witness to a few women screaming as they're digging out the corners. And then I've had patients who told me that their pedicure lady does a better job than me. So I think it's all up to you and what you feel comfortable with. If you are a diabetic, a smoker, you have that peripheral neuropathy, you have any autoimmune illness, absolutely not, because you're more prone to infection. And especially even too, if you take a blood thinner, that's another hard no for me, because they could cut you and you could have excessive bleeding. But if it's something that they're able to cut out in the front of the toe and you're comfortable with it and it's not injuring you, then 100%. But ultimately, when I'm treating ingrown toenails, it's more of like a long-term solution or a recurrent issue, or the ingrown is further in the back where they can't cut it. Most of the time, the pedicure people are treating an ingrown more closer to the skin. And then, so I have extreme neuropathy in my right foot due to a car accident, which caused a broken hip, a broken tibia and fibula, I take medication to help with sensitivity and pain, but I can no longer move my toes. Is there some sort of physical therapy for my toes to help them move again someday? Or is it a permanent thing? I want to be able to wear heels and flip-flops someday. So that's kind of like a hard answer. I could never tell you that just from that kind of question. Part of the physiology and the way any type of nerve injury works. So your nerves control how you sweat. They go to your muscles. They control the function of your muscles. It's not just sensation. So when people get weakness or various other complications like you're talking about, those can be long-term complications from your muscles losing their nerve innervation. So my first recommendation would be to see a neurologist to have what's called a nerve conduction velocity and an EMG if you haven't had one. And it's two types of tests that kind of show how your nerve signals come from your spinal cord down to your toes in your muscle and how fast it happens. And if so, where's the damage? And that kind of gives you an idea of what muscles are working, if they're still working, and what nerves are working. And then ultimately that, if there's other options. Peripheral neuropathy or nerve damage, balance issues, and understanding where you are in space is a really common complication, but physical therapy definitely helps it. And then physical therapy can help with the pain from it too. There's a lot of desensitizing techniques if you find a good physical therapist, but definitely an option. And then I've had a lot of patients who have had awesome results with, all the new CBD and various topical options too, for more long-term relief. Are there any suggestions for increasing your circulation in your feet? So I have a lot of patients who come in are like, my feet are cold, I have bad circulation, but they actually have good circulation. So when people have actual peripheral vascular disease, which is when your blood vessels that come down from your heart have a blockage, which we commonly see with people who are diabetic, people who are smokers, or people just who have a family history of heart disease, there's actual blockage in the arteries. So exercising regularly does help improve it, stopping smoking if you're a smoker, diet changes, but ultimately sometimes that's an actual surgical problem, and it's a severe surgical problem because the complications of that can be detrimental. Some people they feel their circulation's cut off because it can be related to whether it's like, again, a narrow type of shoe, cutting it off. Some people in general, just especially women, tend to have cold sensation in their feet. Again, various topical things, like even using something like Bengay, the nerve stimulation can help with that sensation. But in general, exercising and diet changes are the most important things to improve circulation if you actually do have peripheral vascular disease. Another thing commonly confused with peripheral vascular disease is vein disease, which is a type of vascular disease, but it causes swelling in your legs the more you're on it, heaviness, itching. It's really common in women, especially people who have been standing their whole lives. But it's when the vessels that take the blood back to your heart don't work as efficiently as they should, and they can cause dark spots on your legs or those unsightly blue or purple blood vessels no one wants to see. If you get stepped or fallen on by a horse or pony, there are no signs and symptoms, but should you still consult a trained professional? So for me, it depends how you feel. Obviously, if you hit your head or back, I 100% feel like you should always get it checked, especially if you're an elite athlete, that this is your livelihood. But in general, your body, if you have pain, I would definitely make sure someone knows you're hurt, or not be alone, especially if you've fallen off a horse. And just if sometimes things after the adrenaline of an accident don't manifest till a certain activity or a couple days later. But obviously, if you hit your head, definitely get it checked. But orthopedic wise, most people with your feet, you have some type of pain or symptoms. So I go with, if you have pain, definitely. I've had patients who have swelling or bruising and don't have pain, but I have had broken bones. So if you do have any clinical symptoms, I definitely say it warrants evaluation. But if you feel fine and have no issues, I would just be vigilant and checking and kind of paying attention and listening to your body. when our boot comment was just also explaining she had ingrown toenails, and she added the commentary about the pain of ingrown toenail removal. And just for the record, yes, there's pain with the block, but it's 100% worth it, and it's not as bad as YouTube says. So I've fallen off my, if you've fallen off a horse or have a horse fall on you and fracture or broke a part of your foot or leg, had it treated, but are still hurting, what do you recommend to take for pain? So that kind of depends on what's causing your pain. Some people, it just takes time for your tissue to continue to heal. It's important to make sure you're healed. It's not uncommon for fractures or certain injuries to we have a certain set of time that certain structures should heal in, but people cannot heal in that normal time. Everyone's bodies are different. So one, you have to make sure you're healed, and sometimes that requires more advanced imaging like MRIs or other diagnostic tests. If you have residual inflammation, anti-inflammatories are great, which Motrin, Advil, Aleve, but again, you have to watch with other medications if you have heart issues or acid reflux. Voltaren is great, which is now over the counter. It's essentially a topical form of Motrin. And again, like the CBD products, people are having great results with that. CBD is not FDA approved, but it works very similar to Motrin, Advil, and Aleve. It releases the same anti-inflammatories just through a different pathway. But it's a nice alternative too if you have reflux or can't tolerate the oral medication. But if you continue to have symptoms, I definitely recommend following up and making sure it's not actually something that's being missed, or even another injury that may have been misdiagnosed or missed. And then what looks like the last one, I have a really, keep coming. I have really bad Morton's neuroma in both feet. My podiatrist has just been using cortisone injections. So what else is there? So this is a great answer or question. So there is another option for treatment. Most people start with cortisone because it works well and it's easy. Another alternative is something called a sclerosis injection. So most people try and give no more than 3 steroid injections in an area. That's like a soft rule. After that one, for me, if I'm giving you injections of an anti-inflammatory and you're still having symptoms, we're either missing the diagnosis or just kind of, pardon the pun, beating a dead horse. And we need to either get a little bit more aggressive or change our treatment plan. But the alcohol, what it actually does is essentially shrinks the nerve. Both steroids and alcohol each have their different risks. But in my personal practice, I've had patients who did amazing with the alcohol injections, and I have patients who did amazing with the neuroma. That being said, they're both treating that nerve. Some people need to think outside of the box and also treat what's causing the neuroma, and again, can be the shoes, your actual foot structure. If your bones sit closer together, you may need a metatarsal pad, which can be built into an insole or added to your shoe that sits behind the bone to take the pressure off. So sometimes there's a few more factors that come into play. Okay, and I work with young horses and get stepped on a lot. Is there an easy way to tell between a bad bruise and an actual fracture? So I kind of get this one a lot. There's this great myth that if you can walk on it, it's not broken. Honestly, again, everyone has different pain. The only way to tell if you have a fracture is to have an x-ray. In general, because a lot of people don't come for broken toes to see us because they'll say there's nothing you can do about it. We really only treat them if they're displaced, which means the bones aren't in place, and that usually requires a lot of force. I kind of have a rule of, I tell people if they aren't sure, like a 3-day rule. If you're not improving after 3 days or you can't walk on it, I definitely think it warrants a little further investigation. But there's no way to actually look at a foot and say it's a fracture or not. And that's all my questions. All you, Miranda.
Awesome. Wow.
Thank you guys.
That was excellent. So, wow, so much participation, so many questions. Thank you, everyone, so much. And thank you, of course, Dr. Elizabeth Davis, for a very informational, I know I myself learned a lot. So that was excellent. Thank you so much. And again, thank you to the Wellington Regional Medical Center for sponsoring this session. And I would like to say, please join us next Thursday at 6 p.m. Eastern Standard Time for WEF Week 2. That topic is tips for maintaining overall equine health and longevity, which is sponsored by the Palm Beach Equine Clinic. And don't forget to register directly on the PBIEC website. And when you do register, like I mentioned earlier, you do get one entry to go towards the Karina Brez Jewelry Grand Prize giveaway. So again, thank you very much, everyone, attendees, the speakers, sponsors, everyone. This is such a great informational and very interactive webinar, and hope to see you all next week. Thank you all very much and have an excellent evening.